Welcome to Therapeutics. In this first week block, we're going to be focusing on analgesia and pain management. We'll speak a bit about the principles of pain management, how we approach pain, how it's important for us to differentiate the types of pain so we target our analgesic therapy appropriately to target that type of pain. For acute pain, particularly in the hospital setting, we really focus on the opioids as a mainstay of severe pain, particularly in patients who are post-surgical or trauma patients. But we'll talk about differentiating the opioids and also talk about the risks associated with them. In this age of opioid addiction, we certainly are more careful and judicious in who is a good candidate and who may not be a great candidate for opioid use. But we still do rely on opioids for managing the kind of severe acute pain we see often in hospitalized patients. The non-opioid therapies include the non-steroidal anti-inflammatory agents, which have pros and cons to them. Short-term use in patients without a GI bleed risk and with normal renal function is well established and used frequently. But we do get concerned about long-term use of NSAIDs, particularly in patients who may be predisposed to either renal dysfunction or GI bleeding. We also will talk a bit about adjunctive therapy, which mirrors some of the topics we've talked about elsewhere in the curriculum, including talking about issues of using the anti-epileptic drugs for neuropathic pain and using the antidepressants for pain syndromes as well. Finally, we'll talk about headache, differentiating the types of headaches we see. We'll talk also about the treatment options for different types of headaches and also some discussion about what some of the risks and concerns might be for some of the modalities we have there. And then finally, as an independent outside of this block, focusing in on how to assess the risk and the benefit for patients who are at risk for abuse with opioids, particularly as it relates to patients where opioids would be used in chronic pain. And that's the scope of pain module, which is done really separate from this presentation. But what I would encourage you to think of is to look at the principles that are discussed there, and they begin to give you some approach or tools to think about when you have a patient in front of you who is seeking analgesia with an opioid or is open to an opioid or non-opioid, whatever. But what are their risks that help you decide about when you use opioids, how you use opioids, and what kind of ways that you can or strategies you can do to implement, particularly when we're using opioids longer term in a patient, at their risk for preventing or reducing the risk for ultimate substance abuse. So let's think about the way we classify pain or the nature of pain. One of the big differentiations we make is whether the pain is visceral, somatic, or neuropathic. And visceral pain is usually a dull, achy pain, originates typically in smooth muscle or in the organ. It may be referred to other areas of the body. Presentation can sometimes be different. Somatic pain or nociceptive pain is related to aches from muscles, ligaments, or joints. And this is usually continuously throbbing, achy type of pain. And it can, like visceral pain, vary in severity. Finally, neuropathic pain is a pain that's related to burning or shooting pain, tingling from peripheral nerve injury. We see this commonly in comorbid states related to particularly diabetes, but we can see neuropathic and neuropathies associated with certain drug therapies as well. When we talk about, for example, isoniazid in the management of tuberculosis, we actually, in those cases, give vitamin B6 to help reduce the risk for that type of neuropathy and neuropathic pain associated with it. We can also differentiate pain on its duration. Is it transient, is it acute, or is it chronic? Transient is really activation of nociceptive transducers in the skin or other areas, and this is the classic very short transient pain associated, for example, with a venipuncture or injection. very short-lived, and you expect it to dissipate almost as soon as that insult is complete. There's acute pain, which typically has a more sudden onset and usually a short duration. Sometimes can be moderate, sometimes can be severe. And then chronic pain is, we'll define that as pain that's persistent for a period of up to or greater than 6 months. And we then sub-differentiate acute and chronic pain, whether it's malignant or non-malignant. In malignant, we often think of, for example, as cancer pain. That pain that will, if the condition is not treatable or is not fully manageable, that pain may be for the rest of that person's life. And we usually use that term in the context of cancers. Now, you could argue that chronic malignant pain, really we consider it in practice related to cancer. When you talk about chronic back pain, which could last for years, maybe even someone's life, we don't usually term that as malignant because we try to address that in other ways or other modalities than, for example, the opioids. But we'll come back and talk about that, particularly chronic pain and how we manage chronic pain. And that's also a topic that is really done well in the Scope of Pain initiative we're asking you to complete. So if we look at peripheral pain, typically what you'll see, the physiology of it is related to tissue injury that ultimately leads to production of cyclooxygenase 2 mediated by prostaglandins. Ultimately, that inflammation stimulates the nerve to induce a sensation of significant pain. So to the extent that we can interfere with cyclooxygenase 2, for example, with NSAIDs, and ultimately, as that relates to prostaglandin synthesis peripherally, and inflammation and fluid accumulation and pressure on nerve fibers and the like, that's really an ideal modality to deal with pain that is peripheral in origin. So to the extent that a nonsteroidal, for example, would be safe to use, and we've talked about that through the curriculum, we continue to do that here, nonsteroidals may make sense as a short-term pain management course for peripheral etiologies of pain. Components of pain, one of them is nociception. And this is actually the detection of tissue damage by specialized transducers. And there are particular fibers, the A delta and C fibers are all correlated with that. And we could get into some depth about how those fibers interact and how they fire. But I think probably the easiest way to sort of approach this is to recognize that these transducers are influenced by inflammation and neuronal changes. So our modality for management might be to reduce inflammation, as we just alluded to, perhaps with nonsteroidals, or even on occasion, depending on the circumstance, maybe a corticosteroid, and or we can affect neuronal changes, and we'll talk about the role, particularly in neuropathic pain, of the role of the anti-epileptic or anticonvulsant medicines or the antidepressant medicines in that regard. Particularly, though, aspirin, the nonsteroidals, are useful in affecting inflammation and reducing pain in these states where nociception is a particular etiology of their pain. Another component of pain is perception and what it is that triggers a patient to have a response. It might be triggered by a noxious stimuli like an injury or a disease, and that can be generated either peripherally or centrally. We see the autonomic and somatic nervous system responses in acute pain. We less likely see those in chronic pain. So in acute pain, for example, most often what we see in autonomic nervous system response is an elevated heart rate, sometimes an elevated blood pressure. And that's a response that often, for example, in the intensive care unit, when we have somebody, for example, who's not responsive or is on a respirator or is sedated or the like, but their blood pressure and their heart rate go up and they look agitated, many times we'll look at giving opioids or other analgesics to manage that And we'll often see blood pressure and pulse go down because the etiology of that is pain. In chronic pain, however, we're less likely to see that classic elevated blood pressure and or pulse rate as a response to pain. And pain can occur also without nociception, and that's classically seen, for example, in phantom limb pain, where there isn't a real injury there because, for example, patients had an amputation, but that's the sensation of that. So you can have that as well. And pain due to nerve injury is typically not as responsive to opioids or nonsteroidals, and in those cases, we often look at giving the antiepileptic medications like gabapentin, or we'll look at giving the antidepressants. Sometimes we use the older tricyclic antidepressants carefully there if they're not contraindicated. Other things we think about with pain are suffering and pain behavior. So we've alluded to this pain response in acute pain and over time in chronic pain, how the body may adapt. And so this little chart, as old as it is really helpful to do that, because what we see acutely at pain is physiologically autonomic nervous system responses that help validate, hey, is this, in addition to what the patient is telling me, in addition to the functional assessments I'm looking at, this patient's blood pressure's up, their pulse is up, their respiratory rate is up, their pupils are dilated, they're perspiring, and the behaviors that are listed here as well also are observed. What you have to be careful about, though, is that with patients with chronic pain, their autonomic nervous system, their physiologic responses all adapt to that chronic pain state, and they may very well be in pain, but those physiologic responses aren't seen. And we see this with patients who've had months and months to years of chronic pain over time. And their behavior responses, as it shifts over time, really varies depending on the nature of that patient. And many times there is a concurrent depression, there's a sense of resignation, and very, very frustrating for the patient. And so we need to look at how we assess chronic pain in patients and to recognize that these responses might be what we see when we're trying to make that assessment. So classically in adults and older children, we use the 0 to 10 scale, and that's almost universally accepted, where 0 is no pain and 10 is pain as bad as it can get. So for example, in this example, a patient may complain of 2 on a scale of 0 to 10. Sometimes we'll use what's called a visual analog scale. So instead of a number system, you might have smiley faces on the right and a frown on the left, and it's all equally spaced on a line, and you ask the patient to put an X on a line where their pain is. And so sometimes we call that a visual analog assessment or scale of pain. This is an example of a pain score of 9, for example, where someone says it's about as bad as it ever could be. I can't imagine it being very much worse than it is. And then you're going to sort of settle into make assessments. And typically when you order analgesics, you look at for pain, our score is always to get somebody to 0, maybe depending on the nature, 1 or 2 is a tolerable thing. And we'll look at entering orders, for example, and what you'll often see is for a pain score of 0 to 3, you have maybe acetaminophen, or maybe, depending on the circumstance, in the hospital when you know that there's an acute injury, they're post-surgical, something like that. Maybe you've got a low dose of an opioid, oral, for example, opioid, for a pain score of 0 to 3. For a pain score of 4 to 6, which is considered moderate pain in most situations, you might have a higher oral dose or perhaps a lower IV dose of an opioid. And for pain scores of 7 through 10, you have maybe the highest dose of the parenteral opioid, for example, in an acute care setting, something like that. So as we alluded to pain behaviors already, and here's sort of a table that looks at things again, verbally you'll see patients make sort of sighs, moans, complaints. Motor-wise, you'll often see facial grimacing, limping, rigid or unsustained postural changes. Maybe folks will be excessively slow or labored when they move. Their ability, when patients want to seek help and reduce pain, they may take medications, they may use protective devices, cervical collars, canes, something like that. And you want to also look at their functional limitations if they have them, both at rest and during activity. And so sometimes as a clinician, particularly in an acute care, you may be involving the physical therapist, for example, or the nurse in assessing, tell me behaviorally what kind of things are going on for this patient that help us manage their pain or limit their ability to, for example, participate in physical therapy. In critical care settings, we often have limited data, particularly if a patient is not verbal or not able to tell you that. So the kind of scores, here's an example of one type of behavioral pain scale that's often used, for example, in critical care. We may rely on facial expression, upper limb movements, or compliance. For example, if someone's on a ventilator, are they compliant with their vent? Other sort of situations in a similar way, almost looking at the same kinds of things in here's a different scale, but look at some of the same things: facial expression, body movements, muscle tension, and or compliance with the ventilator if the patient's on it. So all of these are kind of sort of modalities that are looked at in assessing a patient, for example, who might be nonverbal. We haven't really talked about pediatric pain, and we'll talk more about that in pediatrics, but in pediatrics we do the same kind of 0 to 10 scale, but it might be smiley faces. And for newborns or infants, we might look at crying, facial grimacing, and acute pain, also look at autonomic nervous systems as a sign. But in our society now in 2018, we really are in a position where we're looking continuously at sort of walking the tightrope of making sure we're adequately treating pain without over-treating pain. And as a clinician, you will have many pressures from all sides from you to make the right decision. And here are some of the sort of conflicting issues you're going to deal with. There are a lot of things that will lead to undertreatment of pain. One is that the very fear of the opioid epidemic, and that we have so much pressure and concern, fear of addiction and misunderstanding of tolerance, fear of dependence, fear of respiratory depression, and then fear of legal issues for your prescriptive pattern that might be out of line with other prescribers. All of those lead to now an undertreatment or a tendency to potentially undertreat pain. And so you just need to be cognizant that are you making a decision based on external fears or what the patient is really best for that patient, what that patient really needs. And you need to be aware of that and then work with your colleagues both in medicine but also in pharmacy and physical therapy and nursing and chiropractic care and all other modalities, things that the patient might be appropriately open to in holistic approaches to pain management. But your fear of opioids or the fear that we instill about opioids now renders a lot of clinicians to really avoid opioids when they may make sense for the patient. On the other side, and historically this has been a problem, the opioid epidemic has really led to patients who come to you seeking opioids chronically or long-term opioids. The patient's expectations, demands for pain, maybe their expectation is I want zero pain, and maybe for their condition, zero is not a realistic expectation in the short term, but we can get you to a 2. Also, we as a society are overly reliant on pharmacotherapy, and opioids are part of that. And we often are an under-reliance on all other kinds of drug modalities. And if you really look in, particularly in chronic pain, we often see that some of the data, depending on the condition of chronic pain, is that chiropractic approach, physical therapy, TENS units, all kinds of holistic things, massage therapy, even Reiki, things that people who may be open to them really have found that different people find different things that work, and you really need to work toward all of those non-drug modalities. We also need to make sure, in the scope of pain seminar, we'll go through this, really pretty well for you is screening patients for abuse potential and really having adequate follow-up with patients. And so the scope of pain will go through, for example, how to use the state-supported prescription monitoring service before you order opioids for a patient. And that's, in many settings now, that's an expectation that you will do that. In addition, you're going to look at, for using, having good dialogue with patient, documenting that dialogue, you may look at a signed consent statement. Particularly this is expected now in chronic pain management with a patient, a contract with them about what will and won't happen as far as how they will get opioids from you, and then doing urine tests and pill counts. All of that is outlined in the scope of pain, and I encourage you to, when you listen to that, to really take to heart the approaches there, talking at to both best meet the needs of patients to reduce the risk for opioid habituation and problems with opioids, and still at the same point provide really great analgesic care for a patient. So as we alluded to with pain and categories of pain, let's look at differentiating acute from chronic, and then finally in the right-hand column, we're going to call it cancer-related pain. Sometimes we call this malignant pain. The duration of acute pain is usually short, chronic pain long, and cancer pain is across the spectrum. The associated pathology typically in chronic pain is often minimal or none. For example, you have somebody who comes in with chronic back pain and you get an MRI, and the MRI is non-conclusive to anything, and yet that pain may be very real to them. So there may not be a diagnosed or a clear pathology, and so you have to be careful about that. Typically with acute and cancer-related pain, there's a clear pathology that's often identifiable. The prognosis in acute pain is predictable and usually good. With cancer-related pain, we expect increases in pain as, for example, a tumor grows and causes pressure on a patient. And so we expect and understand that that's part of the process. The associated problems with chronic and cancer pain can't be really overemphasized in my mind, because typically for chronic pain, there will be a concurrent, usually depression, anxiety, and then a question about whether or not there is some secondary gain to some behavior that patients may have with chronic pain, really trying to get relief of that pain. And so you need to be at least aware of those issues and manage them appropriately and help really the patient get good control of their pain as well as their corollary issues for anxiety, depression, or whatever. Nerve conduction typically in acute pain is rapid, slower in chronic pain and cancer-related pain as things adapt over time to that pain. And as related to that, early on in pain syndromes, we see elevated heart rate and blood pressure and respiratory rate, which you don't see in chronic or later stages of cancer-related pains. There's a biological high value, of course, for acute pain because that gets people to say, hey, something's wrong, I need to get assessed. But in chronic or cancer-related pain, that biologic value is lower. There are profound social effects with chronic and often with cancer-related pain. And our treatment modalities, particularly in chronic pain, but also in cancer-related pain and even in acute pain, are multimodal. What you're trying to do is have a plan of looking at all of the things you can do to help a patient really get adequate pain control and using non-opioids to the extent that you can, particularly in chronic pain. And again, the scope of pain will help you sort of frame that out or outline that in a reasonable way. So as we get started and think about the specific agents, I think the first thing I'd like to share with you is to think about the different opioid receptors and what an agonist or an antagonist to each of those receptors would do. So let's first look at the mu receptor. And the mu receptor is really the primary receptor we think about when we think about opioids. By giving an agonist at a mu receptor, we see supraspinal analgesia. We see also respiratory depression. It may be associated with euphoria, but also chronic uh, agonist activity at the mu receptor is associated with physical dependence. Mu receptors we classically think primarily associated with the central nervous system, but there are actually mu receptors elsewhere in the body, particularly in the gut, and an activation of a mu receptor will slow down GI motility and actually lead to constipation. So one of the adverse effects of opioids, as we'll talk about, a major one, is the risk for constipation and even impaction. The other two receptors we'll talk about briefly, one is the kappa receptor, also associated with supraspinal analgesia, some sedation, and some pupil constriction, and the delta receptor, which basically has a lot of activity which is not particularly pleasant. It may be associated with some patients who have a dysphoric reaction or even hallucinations or psychomimetic effects associated with opioids. And so that's really an undesirable effect. The first thing we think of are agents that are used as opioids that are agonists at all three of these receptors. And classically, we see morphine, fentanyl, codeine, oxycodone, the classic opioid agonists, even heroin, are agonists at all three of these effects. So what you'd expect, the primary effect we're looking at is the mu receptor effect, but have to recognize those other receptor effects as well are associated with some situation of the kind of physiologic properties you expect to see by an agonist at those receptors. There are the older agonist-antagonists, including pentazocine, which it's not even available really on the market anymore. But it's an older agonist-antagonist that has particularly agonist activity at kappa and delta receptors with an antagonist activity at a mu receptor. There are other, though, related agonist-antagonists that are on the market. And an example to some degree is buprenorphine. There are others as well we'll talk about. Stadol, for example, used in obstetrics. And they're associated with some analgesic property and some sedation, but less risk for respiratory depression, among other things. And so they don't have the full effects. And actually, if they have an antagonist activity at the mu receptor and someone is, for example, habituated on another opioid, a full opioid, then these drugs could actually precipitate a withdrawal reaction for them because we're giving an antagonist at the most common mu receptor. And finally, we have the antagonists at all three receptors, and that's classically naloxone and naltrexone, where they will really bump off an opioid agonist at these receptors, and so what you'll see is reversal of effect to absolutely acute withdrawal. And so giving naloxone to a patient who is on, for example, heroin will improve their respiratory depression dramatically because of the effects at the mu receptor, but may also throw them into acute withdrawal, the blunting of the euphoria, but actually feeling the full withdrawal effects. And we'll talk more about opioid withdrawal and substance abuse block when we get to that and talking about the kind of symptoms associated with opioid withdrawal and also how we quantify that. So therapeutically, let's look at the opioid analgesics, in particular look at the opioid agonists, spend a couple minutes here. These are all classically opioid agonists are used for acute pain management and sometimes chronic pain management. They're all scheduled medications through the DEA. Most of these are Schedule II medicines, and so the limitations associated with Schedule II medicines are clear. Morphine is the classic example of one. It has a fairly short half-life, and as we alluded to already in basic form, morphine also has a moderate first pass effect on oral administration, and so the IV versus the oral dose of morphine is variable. Codeine is a drug that is falling quite a bit out of favor. Codeine is metabolized to morphine by the enzyme cytochrome P450-2D6, but because there is physiologic variation in that enzyme based on genetic predisposition, we see a big variation in codeine response among patients, some not having any effect, others having exaggerated effect. And in fact, the FDA has pretty much recommended no use of codeine in children because the FDA has over the last decade received reports of significant respiratory depression with codeine in patients even with moderate doses of codeine because those patients apparently have a predisposition to conversion of codeine to morphine. Heroin is not a legitimately accepted medicine for use in the United States. Historically, heroin used to be used in hospice patients in the United Kingdom. I don't think that's even in place anymore. Hydrocodone is a commonly used agent, hydromorphone as well. And the other agent on here that's commonly used is, of course, oxycodone near the bottom, available as short and long-acting preparations. So of these agents, you'll see them, probably the four you'll see most commonly used in acute or severe pain is morphine, given IV, immediate release oral, or sustained release oral. You will see hydrocodone typically used orally in combination with acetaminophen, as Vicodin is an example there. Hydromorphone or dilaudid, given orally or IV. Hydromorphone dilaudid is unique in that the dose we give is much less significant, a lower dose, and so you need to be careful about dosing with hydromorphone or dilaudid and not confusing it with dosing for morphine. Also, the other agent here is oxycodone, available orally as an immediate release or sustained release product, either alone or in combination with acetaminophen. The morphine kinetics, as we alluded to, it can be given IV, also subcutaneously or IM, usually sub-Q over IM, because sub-Q is a little more comfortable than IM is. It has a significant first pass effect, as we alluded to. Half-life is pretty short, hour and a half, 2 hours, maybe up to 3 hours. What we find with morphine use in the hospital is that when it's dosed every 4 hours, PRN, between that 2.5 to 3 hour to 4 hour period, patients often have a lot of new breakthrough pain. And so the morphine, in my mind, is best given when it's given IV as intermittent dosing, is best chosen at least a Q2 or Q3 hour dosing regimen as opposed to a Q4 hour dosing. It's also available as a tablet and as controlled release as oral solutions. There's even a rectal form, but we don't use it. And the reason we don't is the variability in morphine absorption rectally, not reliable, and so we're really careful about how we do that. Adverse effects for morphine, as we've alluded to already, probably throughout the curriculum, but the most frequent ones you'll see are central nervous system, dizziness, sedation, and the most concerning ones we have are respiratory depression or apnea. The other one that we're really concerned about, because we see it virtually universally, is severe constipation. And so you will have to expect constipation to happen, and whenever you give morphine, you probably want to give concurrent laxatives. And the laxative regimen we see most often used with any of these really strong opioids. Usually what we see is Senna plus Docusate as a combination, pretty routinely used. And then other, for day 2 without a BM or a hard BM, sort of titrating Senna and Docusate, but adding on bisacodyl, adding on milk and magnesia, adding on, whatever you need to do. Miralax probably also is helpful, but probably not enough for the constipation that we see associated with morphine. Other things you'll see with morphine occasionally are nausea and vomiting. Some folks get upset stomach with it. Sometimes you'll see hypotension. Sometimes you'll see urinary hesitancy. So you need to be aware of that. And you also need to be aware of any additive respiratory depression with other respiratory depressants like barbiturates, but we don't really use barbiturates much anymore. But anything else that is associated with respiratory depression, additive with morphine can be problematic. So you want to keep an eye out for that. The management of toxicity and dependence we'll also talk more about in the substance abuse block, but keep in mind that narcotic analgesics have abuse potential, and so you need to make sure that folks are aware of that when you're using it. You have a little discussion about that. If you're talking about acute use of these agents in acute care, you first of all want to know what the person's risk is for substance abuse before you start. If they're already habituated to opioids, that's going to affect the dose you give, but it's also going to affect the risk-benefit of ongoing use. If someone has remained, off of opioids after they've had a history of opioid problems, and then they get in for acute care, you may want to work with anesthesia to kind of map out a plan that is going to be an analgesic plan that can either be reduced or no opioids, depending on how you do that. Maybe a nerve block, maybe something else that could be used for those folks if possible. But also you want to recognize that you want the patient to be comfortable, and so you need to kind of figure all those things out. And then for acute toxicity and management of acute overdose of opioids, we have Narcan or naloxone at the ready. And again, we'll talk more about that in the substance abuse block, and we manage opioid overdose. A second group of drugs are also opioid agonists, but chemical. Another opioid that can be used is sort of a weaker opioid. I'll use that term weaker. It's sort of used as when you really are trying to avoid the full opioids, but you have significant pain, might be tramadol or Ultram. It's a centrally acting analgesic. It's a synthetic analog of codeine. It is less potential for abuse, perhaps, maybe less potential for respiratory distress, but it is an opioid, and both can occur, so you want to be aware of that. There's also data about how effective tramadol is, but for the most part, what makes sense in my mind is to consider tramadol in the addition of acetaminophen in patients for whom they are perhaps a candidate for an opioid where acetaminophen alone or ibuprofen alone has not really worked. But you want to be aware that there is risk for drug abuse with it. There is a risk for seizures and other problems associated with use. So it's not sort of a perfect agent, but it's an alternative for moderate pain when you kind of want to initiate an opioid but don't want a really full opioid on board. And there's a structural analog to tramadol, tapentadol, which I'll tell you personally, it's been on the market for a decade, and I've not seen it used. Most hospitals, at least I'm aware of, really don't have it on their formulary. When you're looking at opioids, you want to look at what dose do you start with, and one of the questions you're always going to have is the patient opioid naive or not? And by that we mean, does a patient already have opioids on board? Have they had a history of opioids or not? And you want to be cognizant of that because the dose you choose is going to be different. So for somebody who's opioid naive, never had opioids or has not had opioids in a couple of months, for example, or a year, then we're going to start with low dose of opioids and look at the references that you have and base the age of the patient and look at starting appropriately. Now, what we've listed here isn't necessarily starting doses at all. They're just comparative doses. So when you look at this, for example, I would never start parenteral 10 milligrams of morphine or oral 30 milligrams of morphine on an opioid-naive patient, particularly an older one. I would start with much lower doses. So for parenteral morphine, for example, in an older patient, I might start with a dose as low as 1 or 2 milligrams of IV morphine, or maybe 10 milligrams to maybe 15 milligrams of oral immediate release morphine, not these higher doses that you see here. These are just comparison doses. And what we're going to link in the online platform is also we will link a calculator for opioids. Global RPH has one. There are many other ones on the on the web as well that are reliable. And what you'll end up doing is if you're converting somebody from one opioid to another opioid, you'll use these calculators to help guide your therapy. But you need to recognize that these equally analgesic charts or formulas that these conversion platforms will use are not perfect. They're not infallible. And so just be aware of that as a potential concern or risk with approach to care. So as our classes of opioids, here's a couple of different classes. We'll talk at the phenylephrine derivatives are the most common. Those include morphine, oxycodone, hydromorphone, uh, and then the phenylpiperidine, which is really only fentanyl is the one you're going to use. And then the third class we didn't really talk about and really don't use much in pain management with the exception of certain very limited circumstances in palliative care or in folks who are well versed in it is methadone. And we're not going to spend too much time talking about methadone. Methadone is a drug that as a clinician, you probably, particularly as someone in primary care without expertise in pain management, would never, ever order on your own. There are going to be two circumstances you're going to see methadone used. One is for somebody who's on methadone maintenance as part of a protocol for someone who's had a history of opioid abuse. And that is what you might do is you might be continuing their methadone orders, for example, while they're in the hospital, but you first confirm with the methadone clinic what dose they've gotten and will continue that in the hospital and not touch that dose, keep that the same, unless there's some medical reason you need to decrease the dose, but you wouldn't increase the dose. The second issue for methadone is in certain pain management situations, when folks have exhausted all other opioids, methadone may have a role. But the problem is that methadone has pharmacokinetics that are very difficult to manage, very long half-life drug. And so when you make dose adjustments, they can accumulate over days. And what you can end up with is 2 or 3 days later, a person in respiratory arrest when you haven't really changed the dose in 3 days. And so you need to be very much aware of that. Occasionally when folks have true allergic reactions to one of the opioids, we then look at the class of meds they're in and consider picking something from an alternate class. I will say quite honestly, though, true allergies to opioids are rare. The common things you will see is many of these opioids, particularly morphine or codeine, but you can see this with oxycodone, will be associated with nausea, vomiting, and GI upset, or even, they're all associated with constipation, and patients may interpret that and tell you in their history and physical that they're allergic to it. So when somebody says they have an allergy to, pick the drug here, you want to get to the root of what happened when they took it. And if it's nausea, vomiting, that is not an allergic reaction, you'd still want to mark it in their adverse effect or allergic reaction section of their medical record, but you want to qualify that by saying what happened as the reaction. The second kind of pseudo-allergic reaction that happens very commonly with IV morphine is a histamine release with a hives or urticaria-like syndrome, but it is just a release of histamine related to morphine. It is not an IgE-mediated reaction. And so if folks have a hives-like reaction after they've gotten IV morphine, most of the time that is not, if they haven't had any changes in respirations, or respiratory arrest, then that's probably not a problem. But even if respiratory arrest, if that respiratory depression, is that the physiological property of morphine versus is it truly an allergic reaction? So in clinical practice, we find lots of patients who have quote-unquote allergies to an opioid. You want to get to the root of what that is. Another common adverse effect that we see with opioids, particularly in older patients, is that patients have some of those psychomimetic effects of opioids. They might have hallucinations, confusion, agitation. And so we also need to consider that in the assessment of opioids or not. But picking something from a different class in all of these circumstances isn't going to change that outcome. And almost always clinicians really stick primarily to the phenylephrine derivatives when using opioids. So fentanyl has its unique role in anesthesia or in critical care or topically as a transdermal preparation in palliative hospice care. And methadone has a role in methadone maintenance or on rare circumstances as part of anesthesia's pain clinic recommendation or for chronic pain in someone who has failed other modalities. But as a clinician, really pretty much stick to the first column of opioids here. Let me talk about one other thing that we didn't talk about is the phenylpropoxyphene right onto methadone Propoxyphene used to be very commonly used as an opioid, and it is off the market in the United States for the last decade or so. So you may see that as an agent that patient had in their history, but no longer available. All right, one of the things we think about with analgesia and pain management for patients is when we see fluctuations in their opioid blood levels. And so if we're giving an PRN, the only analgesic, you got a post-surgical patient, the only analgesic you offer is a Q6-hour IV or oral morphine dose. And what you've got is they have a lot of pain, they ring the nurse comes, they give them their morphine, in an hour or two they're feeling better, and that lasts for 2 or 3 hours, and then their pain gets worse and worse, and so they get another dose of their morphine, and they go through this cycle of actually early on having mental clouding because we've overshot their analgesic, and then have too long of a window of time. Part of the answer to that is to give somebody, instead of just PRN meds, to give them a fixed schedule of meds. This can be done either with scheduling them not as needed, but instead on a regular basis. And so we have more evenness and approach to that. And so one of our goals in pain management is to try to avoid these really swings in pain and mental clouding and really get folks in a therapeutic range by giving scheduled meds. The way we can achieve that the best is either using long-acting, less variation in levels of the opioid, or more commonly patient-controlled analgesia, which is referred to as PCA. And the advantage of PCA, and usually with PCA or patient-controlled analgesia, and we use this really quite frequently in acute care, is that you might have a continuous infusion low dose of morphine, and then every time a patient has significant pain, they control it if they're conscious enough and with it enough to do it, push a button, and they get a very low dose through their IV or sub-Q pump of their morphine or whatever, fentanyl or whatever drug they're on, diluted, to control that pain. And when we allow patients to respond immediately, instead of calling the nurse and waiting 20 minutes for the nurse to go to the narcotic cabinet and get the meds, come back to the patient and administer it, there's a delay in that. By allowing the patient to do it with the push of a button right away, we subvert that anxiety the patient has about getting their pain med and not wanting to bother people, for example, and get good control. And we find that when folks have PCA morphine, for example, they actually use less pain because they don't get out of pain control and they don't have as much mental clouding. The PCA pumps typically are programmed such that you have a lockout period of time. So, for example, you may have a portion of morphine given as a basal rate continuously over an hour. They may get a milligram over the hour. And then they push the button. Every time they push the button, they get a 0.25 or 0.5 milligrams of morphine every time they push a button. But then if they push a button immediately afterwards, they have a lockout period, a period of usually 6 to 10, maybe 15 minutes, where if they push the button again, they won't get anything until that window is elapsed. And then after 10 minutes or 11 minutes, they push the button again and they can get that dose again. So PCA is routinely used as part of our technical modality we use in many surgical patients. And typically what we'll do, particularly if it's an elective surgery, is we will train people on how to use PCA before they go into surgery, before they get under the influence of anesthesia, so they will remember how to do it when they come out of the PACU and get started on the PCA immediately post-op. So we see this most often in orthopedic surgery, but you can see it in other surgical situations as well. We also use this modality PCA in some other pain conditions, and including chronic pain, but particularly cancer pain. So let's look at some of the comparison of some of the three most common of the opioids you may see, particularly if you're working in a acute or critical care, is morphine, fentanyl, and hydromorphone or dilaudid. And their onset is similar, fentanyl a little faster, and as such, fentanyl is really the agent anesthesiologists use in the OR. The duration of effects are variable depending on the agent, hydromorphone a little longer acting, and where you want to think about whether or not there's a concern in renal or hepatic failure. Interestingly, morphine has some active metabolites that can accumulate in renal failure, so you just need to be aware in patients with renal failure, you may just need to use less morphine. Doesn't mean usually you can't use morphine in renal failure, it just means you need to anticipate that you might have a prolonged action in renal failure. And then the half-life and the duration of action, again, pretty short, as short as an hour or two. So morphine has to be dosed pretty frequently, as does usually fentanyl. Hydromorphone would get by with a little less frequent dosing if need be. The other things we concern about are hypotension and flushing and potential for bronchospasm, and all of the opioids cause constipation. So all of those are things you're weighing out as you're evaluating the patient you've got on their opioid. The partial opioid agonist, now let's spend a minute with that. The classic old agent was pentazocine or Talwin. And I've got this pretty much grayed out because it's an agent that's not used anymore. It's historically of interest for moderate to severe pain. And it's used in certain circumstances, it was used in certain circumstances where we wanted to avoid a full opioid agonist. But in practice, there are a couple agents that are partial opioid agonists that are still used. I want you to be aware of them. The first two now, bufene and butorphanol, are used as analgesics, often in obstetrics in particular, because they bind to kappa receptors and lead to supraspinal analgesia, but they don't block mu receptors. They don't. They're not an agonist at mu receptors. They're an antagonist at mu receptors, and as such, they don't have respiratory depression. So they have some analgesia and no respiratory depression. Why that's good in obstetrics is that it limits the respiratory depression you might see in a newborn. So if you're giving an opioid systemically, we sometimes see in labor and delivery, we sometimes see Stadol or Nubane as a consideration. More often, to avoid that respiratory depression, we often will use an epidural, other full opioid in obstetrics. And the advantage there is if you're giving it epidurally, you have less peripheral levels of that opioid to lead to less respiratory depression in a newborn. The final agent here is buprenorphine, which for buprenorphine we clinically don't use primarily for analgesia. It's primarily used in patients who are opioid dependent, who you're trying to give them an opioid to supplant their heroin use. And we'll talk more about that in the substance abuse block. But keep in mind that buprenorphine itself also can offer some analgesia. And in clinical practice, when we have somebody who comes in the hospital on buprenorphine therapy and needs analgesia, typically what we'll do is we'll take their daily dose of buprenorphine and we'll split it up throughout the day to allow for its moderate analgesic effects to be continuous throughout the day. So that's a common modality we'll see happen in the hospital. But in practice, you're going to see buprenorphine primarily used in substance abuse, and we'll talk about that in that block. As far as the opioid antagonist naloxone, we use this, it can be given intravenously or more commonly in the community setting intranasally. We take the intravenous form, put an adapter on the end of the syringe and administer it with a nasal adapter intranasally, which can be given to reverse an opioid overdose. The concerns we have with naloxone, even in the community now, is that because, and we'll talk more about this in substance abuse, but because much heroin now is cut with either fentanyl or carfentanil, you may need more naloxone in that setting to give a reversal effect with naloxone than you'd expect to see with just plain heroin in the old days. So you sort of need to be aware of that. In the hospital, we also have Narcan available. If we've overshot their legitimate analgesic use in the hospital and you have someone with respiratory depression or respiratory arrest, we'll use naloxone to reverse that abruptly as well. There is a longer-acting naltrexone. Naltrexone has the advantage of a longer half-life, longer duration of action, where naloxone is pretty short. So if you're reversing a long-acting agent like methadone, for example, then you may need multiple doses of naloxone until you know the methadone is out of that person's system, which could be days, or you could consider using naltrexone. More commonly, though, we see naltrexone used as an opioid antagonist associated with management of certain types of substance abuse issues, including opioid, but also we've seen it having some benefit actually in abstinence from alcohol as well. As far as opioids in pediatrics, pain assessment we alluded to is a little more difficult. We might, in newborns or infants, you may not have the verbal complaints that you'll see, and so you may have to rely on behavioral crying, facial grimacing, autonomic nervous system response. And there are also a number of adapted scales, as we alluded to earlier, maybe with smiley faces or something, or frowns compared to the 0 to 10 scale. The difficulty with pediatrics, obviously, is trying to get ahead of the pain and assessing the pain in someone who, may be hard to make that assessment. And you may need to involve family members or family guardian to look at whether or not a behavior, as you're assessing it in pain, is a baseline behavior or if it's indicative perhaps of pain. Interestingly, we have a couple of different choices that were done for pain in newborns or premature infants. The study looked at the pain associated with venipuncture and looking at crying or grimacing associated with venipuncture. And one treatment option was EMLA. We'll talk more about EMLA as a topical anesthetic. It's a topical anesthetic that was applied to the site of IV venipuncture for 30 minutes to an hour before venipuncture. And it's like topical lidocaine or Novocaine to a site that will numb it before you venipuncture. And this study compared that to the use of sugar. And glucose or sugar actually reduced pain more commonly than we saw with EMLA. So we will see in newborn settings sometimes using glucose or a sweetener to manage pain in newborns. Now, if you remember, or one thing we need to consider is that the administration of glucose is a problem when we give, or dextrose, for infants and for children, and can lead to hyponatremia. So a little bit of this goes a long way, a little bit probably not problematic, but too much glucose actually for analgesia could lead in newborns or infants to potential hyponatremia. So be careful of that. In older adults, we're looking at interactions with other drugs. With opioids, we're going to look at their patient who might be stoic. We're going to look at whether or not they're having cognitive impairment or hallucinations or agitation from those psychomimetic effects. And in particular, you have to manage constipation. And so you really need to be very careful about how we do that and aggressive in how we manage that. Okay, let's talk a bit about some non-narcotic analgesics now. And here we're looking at primarily peripherally acting agents, focusing really on the non-steroidals. And these are really going to work on peripheral inflammation and analgesia from a peripheral mechanism. What we're really looking at or focusing here on are the cyclooxygenase inhibitors, the classic non-steroidal anti-inflammatory agents. We're going to talk about acetaminophen as slightly different. Acetaminophen doesn't have as much effect on prostaglandins. It has more effect on other means of pain or analgesia, and so we'll talk about those. But these agents, these nonsteroidals, are particularly effective in reducing inflammation and relieving that peripheral pain. They're also effective in reducing fever, as is acetaminophen. The adverse effects of the classic nonsteroidals, though, are gastric ulceration, suppression of platelet function, and acute renal failure. So we're always cognizant of that and weighing the risk and the benefits. So the mechanism of action of the cyclooxygenase inhibitors are involved as central mechanism in inhibiting cyclooxygenase 1 and or cyclooxygenase 2. And they're pretty similar for all of the nonsteroidals except for celecoxib, which is more specific for cyclooxygenase 2. They're basically anti-inflammatory, and the first generation agents affect both cyclooxygenase 1 and 2, whereas the second generation and the only agent on the market right now is celecoxib, or Celebrex, is a COX-2 only inhibitor. The first generation agents widely used, the classic agents you'll think. Also we have aspirin, and aspirin could historically be used for pain, could be used to lower body temperature as well. However, aspirin really now, because of the risk for GI bleeding, aspirin is pretty much limited to low dose use as an antiplatelet, as we cover in the cardiovascular block. Indications for aspirin historically have been mild to moderate pain and fever. We don't do that. We particularly don't use it for fever or for pain management in children because of the condition of Rye syndrome that's a risk. Where we do use it, though, is to reduce TIA risk and MI. That's really where we see it, aspirin used these days. Aspirin, well absorbed orally, has some metabolic effects excreted by the kidneys. It is potentially fatal in overdose with a salicylate overdose, so you worry about that, and the kinetics are such that it behaves like zero order elimination kinetics, non-concentration dependent kinetics when we saturate the process for its elimination. Adverse effects, as we alluded to with aspirin, GI bleeding. Also, we talk about solicitism, which is listed here, side effects. Just suffice it to say that we don't use aspirin really in this day and age for anything other than low doses and antiplatelet. And aspirin poisoning can be potentially fatal, particularly in children. So we'll talk a bit more about that in toxicology block. There are also some non-acetylated salicylates, choline, magnesium, and sodium salicylate and salicylate. These are agents that are somewhat similar to aspirin. Historically, we use much more commonly. Occasionally, we still see patients on this. They are less likely to cause platelet aggregation, and with patients with chronic renal insufficiency may be less of a problem, although would watch the magnesium salicylate. But suffice to say that these older agents, while occasionally still on the market and used, rarely do we see them used in clinical practice anymore. The nonsteroidal anti-inflammatory agents, though, the ibuprofen, naproxen, for example, all these agents very widely available over the counter, and many patients take these on their own, whether or not they tell you they do. They inhibit cyclooxygenase 1 and 2. They're good for inflammatory types of pain, osteoarthritis pain, although, as we talk about in the osteoarthritis block, we don't really recommend them routinely because of the risk for GI bleeding and the risk for renal failure. They are good for mild to moderate pain. They also will lower temperature. So they're reasonably good agents short-term for all of these in patients who don't have high risk factors associated with the adverse effects of these agents. The other first-generation agents are also effective. In the next slide, we'll go through those. Here are all of them that are on the market. Really, the two that are over the counter that you will see are ibuprofen and naproxen. The remainder of these agents you may not see very often, or you may see on occasion. but for the most part, these are all cyclooxygenase 1 and 2 inhibitors. The two that are prescription only that are more potent and effective short-term in highly inflammatory states like gout or other severe inflammatory states, particularly or acute pain when you're trying to avoid an opioid, might be indomethacin or indocin and ketorolac. Both ketorolac and indomethacin, though, have a pretty high risk for GI bleeding, probably higher than the others, and you want to be aware that they also can increase the risk for renal failure. In the hospital, we actually rely on IV ketorolac a fair amount. We limit its use to up no more than 5 days. That's a recommendation from the FDA as well. And we watch their renal function. We watch their renal perfusion. I would avoid ketorolac in someone who's on another nephrotoxic drug. I would avoid it certainly in a patient with a GI bleed or high GI bleed risk, or patients who are dehydrated who could go into renal failure more easily. So just be aware of the risks with those, but in practice you'll see ketorolac used IV or sometimes oral, in indomethacin oral in severe inflammatory states and pain, but really only use these agents acutely. The kinetics of nonsteroidals pretty well absorbed orally, and the only one that's given IV or can be given IM, but usually IV, is ketorolac. So as we alluded to the nonsteroidals, the risks we have are GI bleeding and renal failure. The other things, though, that I'd worry about is a cardiovascular risk. And this was seen with one of the COX-2 inhibitors that was on the market about 15 years ago by Merck. Vioxx, and this drug has been removed from the market because of the increased risk for MIs. And so any of the nonsteroidals, at least in theory, may pose a risk for increased risk for thrombotic events in an MI. Probably the safest of all of the nonsteroidals in someone with a cardiac history is naproxen. We still would probably want to avoid it if we could, but if you need a nonsteroidal for someone with a cardiac history, maybe naproxen is the safer agent to consider. So contraindications to nonsteroidals are GI bleed, renal insufficiency. Some consider that absolute contraindication. We're also looking at any hypersensitivity history. And interestingly, the nonsteroidals and aspirin, for some patients who have asthma and nasal polyps, might predispose to future asthma. Also, they are relatively contraindicated in hypertension in that they may increase blood pressure and salt retention a bit. And again, as we alluded to, in MI or coronary artery disease, we try to avoid them if we can. The short-acting agents and long-acting agents for the nonsteroidals listed here, naproxen being a longer-acting agent, ibuprofen being a shorter-acting agent. The COX-2 inhibitors, really the only one on the market is celecoxib or Celebrex. It's used for osteoarthritis or rheumatoid arthritis. The risk for GI bleeding is lower than the standard NSAIDs, but it's probably still a risk. The risk for renal failure is probably as great as it is with the other NSAIDs. And there's also the concern with the cardiovascular disease. The older Vioxx and Bextra were notorious for that. Particularly Vioxx was removed from the market because of that. And the older Bextra, no longer on the market either, avoided as well. So of these second-generation agents, only celecoxib is related. It probably has no benefit for folks with renal risk that any other NSAID. Its only advantage really is lower risk for GI bleed. Otherwise, the same risks for other NSAIDs. The concerns and the data for cardiovascular risks first were identified at the turn of the century, and those are still concerns for us now. We just have, even 20 years later, have not really quantified what that risk is for the nonsteroidals in cardiovascular disease. They're not absolute contraindications. They're considered relative contraindications. You weigh the risk and the benefit. But for somebody with a cardiovascular history, we would really try to do well to avoid long-term nonsteroidals. Okay, let's talk about acetaminophen or Tylenol. It is a mainstay of your practice. It inhibits only the prostaglandins that are synthesized in the central nervous system, so it doesn't have any real benefit in peripheral inflammation. It will, however, be effective as an analgesic and also for fever. It doesn't have any antiplatelet effects. It doesn't have any anti-inflammatory effects. Its major adverse effect is hepatotoxicity, and that's only with high dosing or overdosing. Usually the standard dose of acetaminophen, you would not expect hepatotoxicity. It's not a GI irritant, and it has a lower risk for renal insufficiency than the NSAIDs. That said, there is a potential concern for kidney problems with folks who take long-term, daily, high-dose acetaminophen, particularly the combination of acetaminophen with a nonsteroidal long-term. Kinetics, acetaminophen is absorbed well orally, also given rectally. There is an IV form of acetaminophen that's on the market. Most hospitals are loath to add it to the formulary because it's very expensive and probably doesn't offer an advantage to rectal acetaminophen in patients who could tolerate that. And in folks who can't take PO acetaminophen, we always have the option for rectal. All right, let's move to neuropathic pain. In neuropathic pain, we're going to use some of the agents we'll talk about in the neuroblock. We will use first-line agents are gabapentin or the tricyclic antidepressants. Gabapentin is an anticonvulsant that really doesn't work all that well as an anticonvulsant, but it slows nerve conduction. Gabapentin is inexpensive. It's generic. It has to be dosed based on renal function. We'll start folks, an adult but not older patient who has good kidney function on something like 300 milligrams 3 times a day of gabapentin. If they're renally compromised or older patients, we might start on a much lower dose of 100 or 200 milligrams 3 times a day. But for patients who can tolerate it, we can go up to 24, 3,600 milligrams on rare occasion a day, total a day. But on rare occasions, it's even been dosed higher than that. This particular graphic indicates dose of 6,000 milligrams per day of gabapentin. I would be quite hesitant to go anything above 3,600, which is what the usual labeled ceiling dose is. Tricyclic antidepressants, low dose of amitriptyline, or more commonly we'll use nortriptyline with a little less anticholinergic properties, is a consideration for neuropathic pain. Usually we dose it at bedtime. You just want to make sure that patients don't have a history for suicidal ideation because it's a fatal drug and overdose. You also want to make sure that QTs are not prolonged before you started it. If either of those two drugs aren't options for neuropathic pain, then one of the next group of drugs could be consideration. We could look at carbamazepine or Tegretol, anticonvulsant, the antidepressant duloxetine, which many folks consider a great agent for patients who have neuropathic or other pain syndromes where you're trying to avoid other classic analgesics, particularly if they have concurrent depression. That's really a good option in a number of patients. Pregabalin or Lyrica, primarily targeted for patients with fibromyalgia, but in fact it's like gabapentin. Pregabalin is a Schedule IV drug, and gabapentin currently not scheduled, but expect, as we talk about in neuroblock, that gabapentin will eventually be a scheduled drug. And finally, tramadol, that we alluded to already as a controlled drug as well for analgesia as a consideration. But really what we see in practice, probably gabapentin is our first-line agent, which works reasonably well in a number of patients, but sometimes causes CNS clouding for patients as well, so you have to weigh the risk and the benefit of that. Some other treatments here for oral therapies are listed. I won't go in depth, but most of the themes of these agents are they're anticonvulsants or antidepressants, and you can sort of go through this list for most of these agents where they fit. So just so you'd be aware of these as other modalities, but less frequently used when and really only when the other the first or second line agents have been exhausted. We also have some other alternatives for pain, and so you could look at, including topical agents, particularly if you've got a localized area of pain. What we'll see very often for over-the-counter preparations, capsaicin or menthol or camphor like Bengay or salicylate in a topical prep. And then while it's listed in prescription, their lidocaine patches now 5%, just in the last year have rendered over-the-counter. And so lidocaine patches are used topically, transdermally, for some types of pain syndromes when you don't have an excoriated area and it's limited to a particular area, and we'll put on the patch up to 3 patches for up to 12 hours a day. There are other prescription options. Diclofenac, I don't know that there's a lot of great data for that. Doxepin topically, again, I don't think there's great data for it, but it's a possibility. And then there are specifically compounded products, for which I think there's even less great data for. So I would really, if I'm looking at these topical modalities, capsaicin, reasonable for arthritic pain around joints, as is menthol camphor or salicylate. These are like Bengay kind of products that are counter-irritant and provide some warmth and some temporary relief. And then probably lidocaine patch transdermal. The rest of the things that are listed in this table, I have to tell you quite honestly, I'm a little skeptical about how effective they really are. As far as cancer pain and management, and I know we also talk a bit about this, just really not that much, in the oncology block, but the cancer pain we're also making assessments, and we're going to look at oral therapies early on and choosing and layering on analgesics aggressively. And typically you're going to find with cancer pain management, we are going to be aggressive, and we are going to do layered on therapy, working with the oncologist, maybe with the anesthesiologist, assessing pain often and getting ahead of that pain. When cancer pain, we typically, the concerns for opioid and addiction and or habituation are really non-issues in cancer pain. So we deal with that in all other types of situations, but in cancer pain or hospice care, which may or may not be cancer pain management, the concern for habituation opioids are less pronounced, less concerning. The World Health Organization for decades has had this 3-layered step approach where we start with a non-opioid and adjuvant therapy, as we alluded to, and adding on opioids for mild to moderate pain and ultimately aggressive doses of opioids for more severe pain. And that's sort of the classic approach we look at for layering on cancer anesthesia and cancer pain. The non-opioid agents, the non-steroidals and acetaminophen are, depending on the type of situation, helpful. In a cancer patient, though, with non-steroidals, you've got to worry about bleeding risk. And many cancer patients are going to be on anticoagulants because they are in a hypercoagulable state, particularly Lovenox or enoxaparin. So if that's a situation, you want to be careful about using a non-steroidal, which can increase the bleed risk. On the other side of the coin, you have the benefits of the peripheral prostaglandin inhibition if their cancer, for example, has a lot of inflammation. For example, if they have bone metastases, it might be helpful to consider a non-steroidal or maybe dexamethasone or corticosteroid. Acetaminophen, effective for modest pain in patients. The thing you need to worry about is if you have a patient who could have febrile neutropenia, you want to avoid NSAIDs and acetaminophen in masking fever, which may be your only marker that they are febrile neutropenic patients. Other things you'll look at, antidepressants may have a clear role both for concurrent depression in cancer, which is common, but also as if there's a component of neuropathic pain associated with that. Transdermal lidocaine, if it's a localized area, may add. It's not going to be enough, but it may add to that. Corticosteroids as well for nerve compression or dexamethasone for intracranial pressure elevations. Benzodiazepines may make sense both for anxiety but also as skeletal muscle relaxants. If there's muscle spasms, you weigh the risk and the benefit of all of that. Other things we'll look at is biphosphonates related to hypercalcemia, particularly in patients with METs. And then I have no experience with this rankle inhibitor, but it's a monoclonal antibody that I think we've seen used in oncology to promote for folks who have bone mets or skeletal issues related to bone mets. And we see this agent used only really in oncology suites ordered by the oncologist. As far as opioids go, particularly in pain management, recognize that opioids don't have a ceiling dose, and we're going to keep escalating doses over time, partly because patients will develop tolerance to lower doses over time, and partly because many cancer patients will have more infiltration of their tumor as their disease progresses. And so morphine or oxycodone are reasonable agents to consider, as are any of the other strong opioids. We see hydromorphone also used pretty commonly in cancer pain. As well as hydromorphone, you could see fentanyl used or oxymorphone sometimes as well. All of these agents, though, are in cancer pain. You're going to manage it probably in conjunction with the oncologist and or the anesthesiologist, and or if the patient is on hospice palliative care, with the hospice palliative care team. Methadone has a role in chronic cancer pain. Typically, we limit it to patients who have not tolerated other opioids. And the problem with methadone is that it prolongs QT extensively, that it has very complicated kinetics with an extended half-life, which means that you can't really titrate it easily. You can't increase the dose to current pain because it will accumulate over days. And so we really recommend limiting methadone to prescribers who have good experience with it. And if you don't, it'll probably get you into trouble. Other things we think of with cancer pain that we look at trying to manage is whether or not the patient is overly sedated. Usually with opioids, the sedation will reduce in a couple of days of standard therapy, but we weigh the sedation versus good pain control, what the patient needs, and you're going to use everything you can to try to do that. Occasionally we'll see patients in this cohort be adding a stimulant, an amphetamine or Ritalin, to its therapy because of the additive sedation, but the patient wants to be a little bit alert. In addition, keep in mind that patients in cancer, because of the high dose of all the drugs we're using, and or if they have brain mets, may have confusion, dysphoria, hallucinations, and we need to differentiate what that is and maximize our non-opioids in managing that as well. Other things we think of, with any patient with opioids, we're always paying attention to constipation, and in these patients we might have to be very aggressive. Almost always we start with Senna and Docusate and add on top of that. Nausea, vomiting, usually folks tolerate it pretty well, but if it's vestibular, you may want to look at adding meclizine. If it is GI with an opioid, perhaps you give ondansetron concurrent with their dose of their opioid. We also worry about, in morphine in particular, but other opioids, any potential for urinary retention or bladder spasms. That can happen, and so you want to make sure that their discomfort and agitation isn't because they have a full bladder that they can't empty. One last thing I think I'd like to share about with you and encourage you to watch this really short video by Dr. Ira Byock. Dr. Byock is historically was at Dartmouth Medical Center in Hanover, New Hampshire, or Lebanon, New Hampshire, for a long time as a palliative care national expert, and he's recently shifted his practice to another part of the country. But he was considered really one of the founding fathers in the United States of palliative and hospice care. And he gives, even though this is a somewhat dated presentation, really gives you the philosophy and the sense of palliative care and pain management. And what he really looks at is, and what palliative care and hospice care is really about, is choosing symptom relief over cure. And what we're looking for symptom relief of is physical symptom relief, mental, spiritual, and emotional. And a lot of that has to do with analgesic approaches, but also anxiety, and recognize that patients have the right to be free of pain and excessive anxiety, and important that we do that. Dr. Bayek's presentation here really talks about dying well, and we're posting it on the online platform as well for you. Some key interventions for patients, particularly who are actively dying, are opioids for pain, and also what we didn't talk about here but is used in palliative care is morphine or another opioid for a sense of breathlessness. And so while we, in most of the patients, are concerned about respiratory depression in patients who are on opioids, in end-stage palliative care patients who have a sense of breathlessness, morphine or other opioids actually give them a sense of relief of air hunger, which is common in these patients. We also commonly will give anxiolytics or antipsychotics as need be, lorazepam for anxiety, Haldol for agitation, keeping in mind that we're talking here about actively dying patients as opposed to patients who are not that far along, for which particularly lorazepam or the benzos could actually induce delirium or confusion. So we weigh the risk and the benefit, but in these patients who are near end stage, we really do aggressively manage their anxiety and their psychoses. We often will use an antimuscarinic for anticholinergic dry secretions. That could be scopolamine transdermal, or very commonly we use atropine ophthalmic eye drops given sublingually. We also will avoid hydration, which prolongs suffering in folks who are very end stage and are actively dying. We'll use antiemetics, laxatives, antidiarrheals, anything symptom management, create the environment that is home-like and respectful, and be honest with patients about what their expectations are. I have a colleague who works in palliative care, hospice care, and is very proud of the practice that palliative and hospice care nurses give, and has really described really someone who is effective in hospice care, particularly end-stage hospice care, as serving as a midwife on the other end of life, really helping them through that difficult passage by letting them know what to expect, what to see in practice, what the patient's likely to see, what the family's likely to see. And then when people know what to expect somewhat, there is less fear, and there is more a sort of acceptance and peacefulness in that process. Okay, a list of number of drugs where we expect you to recognize some